So, welcome back to the latest episode in our series of mental health podcasts. I'm Helen Winter. I'm a GP with extended role in psychiatry, and I work in the primary and community mental health team, PCMHT. And I'm joined by Pranav Mahajan, who's going to introduce himself.
Hi, I'm Pranav, and I am the consultant psychiatrist in PCMHT.
Great. So today we're going to discuss metabolic complications in severe mental illness, which is a topic that's important for all of us to be aware of, especially in primary care.
Absolutely. So there's now a vast amount of evidence to show that people with severe mental illness die sort of on average 15 to 20 years earlier than the general population. And this is largely due to sort of cardiometabolic diseases. And up to a third of people with SMI or severe mental illness go on to develop metabolic syndrome.
Gosh, those are some stark statistics, aren't they? But I suppose the key thing here is that with timely intervention, these complications are preventable and reversible. And Pranav, you mentioned metabolic syndrome. Can you tell us what that is?
Yeah, metabolic syndrome, it's sort of an umbrella term really of a cluster of signs and symptoms which lead to a significant increase in the risk of developing cardiovascular disease. So the main ones are insulin resistance, so that's normally evidenced by an abnormal fasting glucose or an abnormal HbA1c, central obesity, hypertension, and abnormal lipids, but specifically high triglycerides and a low HDL cholesterol.
Okay, so it's clear that impairment in these parameters can lead to an increased risk of MI, stroke, liver disease, and type 2 diabetes. And in general practice, we see these conditions all the time. And many of those patients don't have mental health conditions. So it's interesting to think about, why is it so much more prevalent in patients with severe mental illness?
Yeah, that's a fair point, and these things are prevalent across sort of the population, but there are a number of factors that increase the risk of metabolic syndrome, and some of those disproportionately impact on people with SMI compared to the general population. And some of those are unique with those with severe mental illness. So the main ones that increase the risk that disproportionately impact are things like lifestyle choices or lifestyle factors, such as poor diet and smoking. And studies have actually shown that whilst the rates of smoking across the general population have dropped over time with many sort of public health interventions, they've remained stable in those with severe mental illness. Poor diet, and that can be exacerbated by psychological factors such as poor motivation to cook or to source healthier food. Social factors such as not developing the skills to cook food, or being in accommodation that doesn't allow them to cook food. There's a lot of accommodation out there that just have a microwave, for example. And also not being able to afford sort of healthier foods.
Yeah, that's interesting. And I wonder if healthier foods are always more expensive, or if the availability of healthier choices and education around healthy diet and choices and lifestyle may also contribute to this.
Yeah, absolutely. I think sometimes when we say that healthy food is more expensive, many people will look in their supermarkets and say, well, it's only 80p for a floret of broccoli or what have you. But I always think back to this presentation that I had to give, or I was asked to give at the Royal College a couple of years ago, about nutrition and the barriers to good nutrition. And I found this parliamentary document that explored this, and they were able to demonstrate that whilst, yes, in sort of larger supermarkets, fruit and veg is cheaper, in many sort of deprived areas, so especially inner city areas and rural locations, the access to these massive supermarkets is limited. And so instead, people are using corner shops, mini marts, and takeaway shops as their main sources of food. And these sorts of shops were far more prevalent on the high streets. And And that's when the unhealthy options are often cheaper and portion control can be much harder. So that document itself, it wasn't looking at the economic deprivation. Sorry, it was looking at economic deprivation and not specifically severe mental illness, but we know that severe mental illness and deprivation often go hand in hand. So I think you could sort of see how this can then compound the issue. And then when we're talking about compounding the issue, we as sort of health professionals sometimes don't help either. The medication that we use, certainly things like antipsychotics or mirtazapine, that can increase appetite and increase insulin resistance. And people with severe mental illness can sometimes be less likely to access help from health professionals, either due to stigma or being suspicious of health services, depending on their previous experiences. And I guess for you, Helen, as sort of on the front line, really, as a GP, I was wondering what you thought about what could be done in primary care to help reduce the risk of metabolic syndrome.
Yes, it's interesting thinking of it in the primary care and the GP setting, and I'm thinking mainly about the opportunity that is presented to us as GPs and in primary care at the annual SMI review, because all patients with SMI who are on the register would be invited for an annual review. And this is a chance to discuss lifestyle factors and risk factors. So it is really important to ensure that SMI checks are done and that the lists that we have in practice are up to date. And I definitely know from experience of looking after people in general practice that it can be really tricky to engage patients for the annual checks, particularly if they're feeling well. Commonly people sort of, might decline an invite because they feel that it's not needed or that they're already being perhaps looked after elsewhere. So it can be really helpful, I think, to proactively contact patients to explain the reason for the appointment and the importance of the process, as well as to make sure that the appointment time and venue and things that are accessible to them, just to try to capture as many people as possible in the process. The other thing is opportunistic brief interventions around risk factors such as smoking, alcohol, weight, substance use. This can be considered when patients present to the surgery for other reasons, as well as not just only thinking about it at the annual SMI review. And obviously we recognise that particularly in general practice, time pressures can make this tricky. But if this conversation is started when the patient's there for something else, then at least another appointment can be booked in if needed. But there's the opportunity to discuss with the patient at the time and explain what the purpose is for that. So hopefully to improve the likelihood of the patient coming back for that next check or the next steps. And often in general practice, that initial discussion might lead to signposting to other services that can support in those interventions that might be helpful to them, such as weight management and smoking cessation support in the community. So signposting opportunities should be taken really whenever we can. And as we're aware that SMI patients often don't attend GP surgeries as frequently, perhaps, as other patients, then there may be opportunities for practices to more proactively reach out to those who are increased risk, to seek engagement with screening for other medical conditions. As we've mentioned, they may be less likely to attend for opportunistic screening. And I think it's helpful to try and reach out to explain the processes to try to engage people as needed. And I'd be interested to know, Pranav, what you think about what point would you expect a GP to refer to secondary mental health services for support with metabolic concerns?
Yeah, good question. So I think that secondary mental health services should always be available for support and advice, and picking up on those risk factors early is helpful. I would look at it from a case by case basis and sort of understanding the underlying causes that we've mentioned before. It may be for example, that support from the wider multidisciplinary team to support people in building skills, looking at their finances, building a routine with regular physical activity, or supporting with lifestyle changes can make a difference. Medication reviews could always be a useful thing to look at, and where possible, reducing doses or switching to other options could be considered.
Yes, I'm interested to know what you think about which medications you would consider in this kind of situation. Are there good ones and bad ones to consider in respect to the metabolic complications that can arise?
Yeah, again, I think we have to look at things on a case by case basis, and for some people, switching or reducing doses just isn't an option because we know from their history that no other medications or no other doses have kept them stable. But we do know that some antipsychotics are higher risk for metabolic syndrome. So so medications such as olanzapine and clozapine carry the highest risk. Antipsychotics like quetiapine and risperidone, they carry sort of a moderate risk, and aripiprazole is one of the only antipsychotics that's deemed low risk. We then know that there are other antipsychotics that may have less impact on things like insulin resistance, but may still increase appetite. So again, it can very much depend on the underlying causes, as mentioned above. But as I was sort of mentioning, ultimately, the decision around changing medication is always a balance between risk and benefits, and that's why monitoring and intervening holistically and early is so important. And I would be remiss if I didn't use this opportunity to plug the podcast that we have available on YouTube and Spotify, looking at deprescribing, which hopefully people listening to this would also find useful.
Yes, that's great. I mean, I think it's quite possibly a good place to end this podcast with a plug for the next one. So absolutely, please do listen to the podcast on deprescribing. And thank you, everybody, for listening today to this discussion about metabolic complications in severe mental illness.